I'm going to show images of X-linked adrenoleukodystrophy, which is a problem with the lipid metabolism leading to accumulation of very long-chain fatty acids in the white matter of the brain and in the adrenal glands. Coincidentally, this year there was a teaching neuroimage in neurology of a 6-year-old boy with typical imaging findings of X-linked adrenoleukodystrophy with parieto-occipital white matter abnormalities with an enhancing zone and also abnormalities on spectroscopy. And he presented with learning difficulties and visual problems caused by the involvement of the lateral geniculate nucleus of the thalamus in this parieto-occipital predominant pattern, hypotension and a hyperpigmented skin, which was caused by the adrenal problems. About 20 years ago, the group by Luce looked at the patterns of white matter involvement in patients with X-linked adrenoleukodystrophy, and the majority of pediatric patients, about 85%, have a parieto-occipital pattern, and the remaining 15% have a frontal predominance. And if you give contrast and if there's contrast enhancement, the prognosis is worse and the patient will deteriorate more rapidly than patients who do not have contrast enhancement. In adult patients, there's involvement of the corticospinal tract. In adolescents, typically the corticospinal tract and the cerebellum. And in a very small minority, there's involvement of both anterior and posterior white matter involvement in children, and this has the worst prognosis. If you think of the majority with a parieto-occipital pattern, you can think in the differential diagnosis of a lymphoma or macchia-fava binyami, or a mild encephalitis with a reversible splenial lesion, but these are all entities that you see in adults, and this is the adrenoleukodystrophy pattern of a child, whereas adults would have a corticospinal pattern if it is adrenoleukodystrophy. If you look at the pathogenesis on a molecular level and you try to imagine the molecular structure of the fatty acids, you might remember that fatty acids have a carboxy group and that you have unsaturated fatty acids where there are carbon atoms that are not occupied by 2 hydrogen atoms, and there are saturated fatty acids where every carbon atom is saturated by 2 protons. And what happens in the endoplasmatic reticulum of the cell is that the fatty acid chains become longer and longer, so there are carbon molecules added, and they become saturated. And the very long chain fatty acids that are saturated are toxic for the cell, so they have to be broken down again. And the breakdown of these very long chain fatty acids is done in the peroxisome, and the peroxisome is an organelle with a membrane and some channels in this membrane, and one of the channels is the adrenoleukodystrophy protein. And if that is missing, these very long chain fatty acids cannot enter the peroxisome, and they become longer and longer and get incorporated into complex lipids and are toxic for the cell. There is an escape route that's called omega oxidation, and what happens is that there are 2 carboxy groups for a very long chain fatty acids, and these dicarboxylic very long chain fatty acids can enter the peroxisome by another channel and then be degraded. So this route might be an escape route, might explain the phenotypical variation, and might be a route for therapy for X-linked adrenoleukodystrophy. If you look at an imaging level. In modern literature, it says you should wait for the enhancement for at least 5 minutes because it takes some time for the enhancement, so don't image too quickly. But when the first patients with X-linked adrenoleukodystrophy were imaged in the 80s, the scanning time and the acquisition time was over 5 minutes, so then you did not have to mention that. So these are very early images of adrenoleukodystrophy. And you can see that there are different zones. There is a very T1 hypointense zone, there's an enhancing rim, and there is an outer zone. And when you look at the histology, you can see that the very hypointense T1 zone corresponds to the area of complete demyelination and reactive astrogliosis. The enhancing zone corresponds to active demyelination, and the outer zone, which might look normal, already has some demyelination. So the demyelination precedes the inflammation on imaging. And another interesting thing is that in the early stage of X-linked adrenoleukodystrophy, the U fibers are spared. And we've seen that also in HIV encephalopathy, which was a microglial problem. And the white matter cell that is involved early in X-linked adrenoleukodystrophy is the microglial cell. So it's the peroxisome in the microglial cell that is abnormal in X-linked adrenoleukodystrophy. In the next vlog, we're going to look at another microglial-related leukodystrophy with a problem in the lysosome, which is metachromatic leukodystrophy, and that also has